If you were to use a standard localized vaginal estrogen treatment um, every single day for an entire year, the total amount of estrogen entering your body would roughly equal just one single 1 milligram pill of systemic hormone therapy.
Right, which is, I mean, it's wild, isn't it? An entire year of local treatment equals just a single day of a systemic pill.
It's crazy. Okay, let's unpack this. Welcome to today's deep dive.
Glad to be here.
So whether you're, navigating menopause yourself, maybe supporting a partner, or you're just insanely curious about medical science, we have a very clear mission today.
We really do.
We're looking closely at localized vaginal estrogen therapy to answer a question that, frankly, causes a lot of anxiety, which is, does it carry the same risks as systemic hormone replacement therapy?
And to get to the bottom of that, we're drawing on a really solid stack of sources. I've got a 2023 systematic review by Ishrat Hussain, the latest clinical guidelines from the NHS and the British Menopause Society, plus FDA drug monographs for local products like Estring and Vagifem, and, some expert clinical insights too. And the data here really forces us to separate the word estrogen from all those systemic assumptions we've kind of attached to it over the years.
Because the reality is, to understand the treatment, you really have to understand the specific physical environment it's trying to fix.
Exactly.
During menopause, the systemic drop in estrogen creates this whole cascade of local issues, and these fall under the medical umbrella of GSM, which stands for genitourinary syndrome of menopause.
Yeah, and it's a highly descriptive term because it captures the true breadth of the condition. Like, previously it was just called vaginal atrophy, but the effects extend well beyond just that.
Why, it's not just one thing.
Exactly. The lower genital tract and the lower urinary tract actually share the exact same embryological origin, meaning they both rely really heavily on estrogen to just, maintain their structure and function.
So they're deeply connected.
Very deeply. When estrogen levels plummet, the tissues in the vulva, the vagina, the bladder, and the urethra, they all undergo profound physical changes.
Yeah, the sources detail how that tissue literally loses its elasticity and its collagen. I mean, it physically thins out.
It does, and for the person experiencing it, this translates to severe dryness, burning, and pain during intimacy.
But because of that shared urinary tract connection you mentioned, you also see this dramatic spike in recurrent urinary tract infections, right?
Yes. What's fascinating here is the underlying cellular mechanism that leads to those infections, because estrogen essentially fuels the local microbiome.
Oh, wow. Okay.
Yeah, so in a healthy premenopausal state, estrogen causes the cells lining the vagina to produce glycogen. And that glycogen is like the primary food source for lactobacilli.
The beneficial bacteria.
Exactly, the good bacteria that populate the area. So as the lactobacilli consume the glycogen, they produce lactic acid, which keeps the local pH really low, typically below 4.5.
So it's a highly acidic environment by design.
Precisely. That acidity is a functional barrier. Competing pathogens and bad bacteria simply cannot survive or multiply in an environment with a pH below 4.5.
That makes sense.
But when systemic estrogen vanishes, the glycogen production just halts. The lactobacilli starve, the lactic acid disappears, and suddenly the local pH rises above 5.
And the environment becomes incredibly hospitable to the bacteria that cause UTIs.
Exactly. The entire ecosystem effectively collapses.
Which brings us to this brilliant analogy from one of our sources, the Women's Health Clinic. They describe systemic HRT, meaning the patches or pills that circulate through your whole body, as a sprinkler system.
I love that analogy.
Right. It waters the entire garden, which is highly effective for systemic symptoms like hot flushes and brain fog. But local vaginal estrogen is a watering can. It delivers water directly to the roots of one specific plant.
It's a perfect visualization, and it really highlights a crucial clinical reality, which is that the sprinkler system doesn't always reach the deepest roots.
Wait, so logically you would think if someone is already taking systemic HRT, the sprinkler's running, right? The estrogen is in their bloodstream. So why wouldn't that resolve the local GSM symptoms? Why do they need the watering can at all?
Well, it really comes down to blood flow and tissue degradation. Up to 25% of women taking systemic HRT still experience significant GSM symptoms.
That is a huge number.
It is. When the tissues of the vagina and urinary tract atrophy from an initial lack of estrogen, the local blood vessels shrink and become compromised. So even when you introduce systemic HRT into the bloodstream,
The circulation is just too poor to deliver it.
exactly, the circulation in that specific pelvic area is often too poor to deliver the hormones in high enough quantities to reverse the atrophy.
So the medication is in the system, but the plumbing is too degraded to get it to the destination.
That's a great way to put it. The systemic dose is diluted across the entire body, and the local tissue simply doesn't absorb enough of it to restart that whole glycogen and lactobacilli cycle.
Wow.
And this biological limitation is why major healthcare organizations like NICE in the UK explicitly recommend offering local vaginal estrogen even to patients who are already on a full dose of systemic HRT.
Now, understanding that physical limitation completely changes how we look at the local therapies themselves. When we switch from the sprinkler to the watering can, we are talking about delivering estrogen directly to the tissue that needs it.
Right, it's the source.
Our sources list a few delivery methods. There are creams like Ovastin, small dissolvable tablets like Vagifem, and silicone rings like S-string.
And because they're applied directly to the surface of the tissue, they bypass that compromised blood flow entirely. They absorb straight into the local cells.
Which is amazing.
It is. This targeted delivery begins rebuilding the epithelium, which is the outer layer of mucosal cells lining the tissue. As those cells mature and plump up, the glycogen returns, the lactobacilli recover, the pH drops, and the tissue regains its elasticity.
And its defense against UTIs.
Exactly.
Here's where it gets really interesting, though. Because these treatments are delivered directly to the tissue, the amount of estrogen required is incredibly small. Looking at the FDA monograph for E-string, the ring sits in place and releases precisely 7.5 micrograms of estradiol a day.
Tiny amounts.
All right, Vagifem tablets are typically 10 micrograms. This brings us back to that staggering statistic from the British Society of Sexual Medicine from the beginning. A standard 10 microgram daily dose for a year equates to a single 1 milligram systemic pill.
The microdosing scale is really the defining characteristic of local therapy, and it fundamentally alters how the body processes the hormone.
How so?
Well, when you take systemic estrogen, say a daily pill, that larger dose circulates everywhere, including the uterus, and estrogen's primary job is to stimulate cell growth. So in the uterus, unopposed systemic estrogen causes the endometrium, the inner lining, to thicken continuously.
Which is a condition called endometrial hyperplasia. And if that cell growth goes unchecked, it can eventually lead to cancer.
Correct. So to counteract that risk, anyone taking systemic estrogen who still has a uterus must take a second hormone, a progestogen. The progestogen essentially acts as a chemical signal to stop the growth and shed the lining.
We have to balance it out.
Right. You have to balance the systemic estrogen with a systemic progestogen.
But with local vaginal estrogen, we're dealing with doses of 7.5 to 10 micrograms. That is such a minuscule amount that it doesn't circulate through the body in high enough concentrations to reach the uterus and trigger that endometrial cell growth.
Exactly.
So women using local estrogen generally do not need to take a protective progestogen.
That's right. The localized dose is simply too small to initiate that systemic cascade. It acts on the vaginal epithelium and goes no further in any clinically significant amount.
Which is a crucial distinction. But, even with that microdosing scale established, we still have to confront the anxiety surrounding the word estrogen.
Oh, absolutely.
The legacy of the Women's Health Initiative, the WHI trial from the early 2000s, is still very much alive.
Yeah.
That trial closely linked systemic HRT to serious cardiovascular events like deep vein thrombosis, stroke, and breast cancer.
The WHI trial undeniably shaped a generation's understanding of hormone therapy. But again, we have to look at pharmacokinetics, how a specific drug moves through and is metabolized by the body. Systemic oral estrogen has to pass through the digestive system and the liver before it enters general circulation. This process, known as first-pass metabolism, directly affects the liver's production of clotting factors, which is what elevates the risk of deep vein thrombosis and stroke.
But local vaginal estrogen bypasses the liver entirely. It absorbs directly into the local tissue.
Exactly. And the FDA data for estring shows that only about 8% of that tiny 7.5 microgram daily dose actually makes it into the systemic bloodstream.
Wow, just 8% of an already tiny dose.
Yeah. When researchers test the blood serum of women using these low-dose local products, their circulating estrogen levels are virtually indistinguishable from the normal, untreated baselines of postmenopausal women.
That's incredible.
The estrogen isn't altering liver function, and it isn't circulating in high enough volumes to trigger systemic events.
Wait a minute, though. I was actually looking at a warning from the European Medicines Agency, the EMA, in our sources that seemed to contradict this.
Oh, the cream warning.
Yeah. It mandates that high-strength estradiol creams must be restricted to just 4 weeks of use, specifically because of the risks of blood clots and cancer. If local estrogen stays local and bypasses the liver, Why is there a strict 4-week cap on these creams?
Well, if we connect this to the bigger picture of dosage, that EMA warning actually makes perfect sense. The restriction specifically applies to high-strength creams.
High strength meaning what,
That's
exactly?
meaning they contain concentrations of 100 micrograms of estradiol per gram of cream. That is 10 times the dose of a standard 10 microgram tablet.
Ah. So the watering can is suddenly pouring a lot more water.
Much more. Pharmacokinetic data shows that when a woman applies a 100 microgram cream, her blood serum levels of estrogen can spike up to 5 times the normal postmenopausal limit.
Oh, wow.
Yeah, so at that concentration, the body can no longer contain the hormone locally. It spills over into the bloodstream in significant volumes. It essentially ceases to be a local treatment and begins acting systemically.
Okay, that totally explains the 4-week limit. You don't want those systemic spikes continuing indefinitely without monitoring or opposing progestogen.
Exactly.
But for the standard low-dose therapies, the 10 microgram tablets, the
Mhm.
0.01% creams, the 7.5 microgram rings, they don't trigger that spillover.
Right. Because their dosage is just a fraction of the high-strength products, they maintain that steady, localized state. The NHS, the British Menopause Society, and the FDA monographs all confirm that these specific low-dose options are safe for long-term indefinite use.
So the specific formulation is everything. Now, to truly understand the safety profile of these low-dose localized treatments, we can look at how they perform in the ultimate stress test.
The breast cancer data.
Yes. The 2023 systematic review by Ishrat Hussain focuses on perhaps the most vulnerable population possible
Yep.
regarding estrogen exposure breast cancer survivors.
This is an incredibly important area of clinical research. For patients who have survived estrogen receptor-positive breast cancer, systemic estrogen therapy is universally contraindicated.
Because it's too dangerous.
Exactly. The medical imperative is to avoid introducing any estrogen into the system that might stimulate dormant cancer cells and trigger a recurrence.
But because breast cancer treatments deliberately suppress or eradicate the body's remaining estrogen, these survivors frequently experience the most severe, debilitating symptoms of genitourinary syndrome of menopause.
It's a brutal catch-22.
It really is.
Yeah.
The treatment that saved their life destroys their daily quality of life, and the standard cure for that pain is the one hormone they are told to avoid.
It's a profound clinical dilemma. But the Hussain Review analyzed randomized clinical trials, which is, the highest standard of medical evidence, to see what actually happens when these survivors use low-dose vaginal estrogen.
And what did they find?
The findings are highly reassuring. Among the current trials actively observing for adverse effects, none have reported an increased incidence of breast cancer recurrence linked to local vaginal estrogen.
Which sounds completely counterintuitive if you view all estrogen as a systemic threat. How does the biology actually protect them?
It involves a fascinating biological mechanism. When a patient first begins local estrogen therapy, her vaginal wall is in an atrophic state. The epithelium is extremely thin, perhaps only a few cell layers deep, and highly permeable.
Right, because of the atrophy.
Exactly. Because the tissue is so fragile, when the local estrogen is first applied, a slightly higher amount of it does slip through that thin tissue and enter the systemic bloodstream.
So there is a window where it does hit the general circulation before the tissue repairs itself.
Yes, there is a temporary leak. But over the next 2 to 4 weeks, the local estrogen stimulates the epithelial cells. They mature, they multiply, and they stack up, thickening the vaginal wall.
Oh, I see.
The tissue literally builds its own structural integrity. Once that healthy, thick mucosal barrier is restored, it acts as a physical shield. The systemic absorption of the local estrogen rapidly drops back down to a negligible baseline.
The medicine essentially builds the wall that keeps the medicine exactly where it needs to be. It's a self-sealing system.
That's a great way to put it.
But the sources do add a critical layer of nuance here, depending heavily on the specific type of medication the survivor is taking to prevent cancer recurrence. There are two main categories, right? Tamoxifen and aromatase inhibitors.
Yes, and this requires us to look closely at how those specific oncology drugs function at the cellular level. Tamoxifen is what's known as a selective estrogen receptor modulator, or a SERM.
Okay.
A helpful way to think about it is like a bouncer at a club. Tamoxifen molecules actively bind to the estrogen receptors in breast tissue, effectively blocking the door.
So if a patient on tamoxifen experiences that temporary 2 to 4 week leak when they start vaginal estrogen, The leaked hormone might circulate, but it can't enter the breast tissue cells.
Exactly. The tamoxifen is already guarding the receptors. The leaked estrogen is blocked from stimulating the tissue.
But aromatase inhibitors, or AIs, function very differently. They don't
Or
block the receptors at all.
No, they don't. Aromatase inhibitors work by shutting down the body's ability to synthesize estrogen in the peripheral tissues. They essentially close the factory.
Oh.
Because the body isn't producing any estrogen, the receptors in the breast tissue don't need a bouncer. They're left entirely unguarded.
So what does that mean when a patient on an AI starts local vaginal therapy?
Well, it raises an important question for oncologists. If a patient on an AI experiences that initial leak through the thin vaginal tissue, that leaked estrogen, enters the bloodstream and encounters those unguarded receptors in the breast tissue.
Because it bypasses the AI's mechanism of action entirely.
Precisely. The AI only stops the production of estrogen. It doesn't stop external estrogen from binding if it gets into the system. And while the clinical trials haven't shown an overall increase in cancer recurrence, some observational data suggests a theoretical risk specifically for this subgroup of patients taking AIs.
And this biological vulnerability is why clinical guidelines dictate a very careful, stepwise approach.
Exactly. The sources outline that for women on AIs, the first line of defense is usually non-hormonal moisturizers and lubricants like Replens.
That's the recommended starting point. But if those non-hormonal options fail to provide relief and the severe pain and urinary issues continue, the oncology team has to evaluate the next step.
Right. In some cases, rather than risk the unguarded receptors, they might choose to switch the patient from an aromatase inhibitor to tamoxifen.
Oh, I see. By changing the cancer drug, they install that receptor blockade.
Exactly, making it safer to introduce the local vaginal estrogen.
It's this intricate balancing act between the specific mechanisms of the oncology drugs and the pharmacokinetics of the local therapy. It makes it very clear why navigating this requires close coordination with an oncologist.
It is individualized medicine in its purest form. You have to understand exactly how the specific molecules are interacting within the patient's unique biological environment.
So what does this all mean for how we view these treatments? Systemic HRT and localized vaginal estrogen clearly share a name, but they operate through entirely different biological pathways.
They really do.
Systemic HRT treats the whole body, but is limited by the physical degradation of local blood flow. Local estrogen bypasses the blood flow, utilizing microscopic doses and a self-sealing mucosal barrier to provide targeted relief with virtually zero systemic footprint.
And by understanding these mechanisms, we can finally decouple the fear of systemic risks, like those seen in the WHI trial, from the reality of local low-dose relief. The biology simply doesn't support applying the same risk profile to both treatments.
And what's wild is that medical science is pushing this targeted approach even further.
Oh, definitely.
The Hussein Review mentions a process called endocrinology, which takes the concept of local delivery to an entirely different level. We're talking about a treatment known as DHEA, or progesterone.
DHEA is fascinating because it isn't actually estrogen. It's an inactive precursor molecule. It's delivered locally into the vagina, but it remains inactive until it's absorbed directly inside the vaginal cells.
Wait, inside the cells?
Yes. Once inside the cell, local enzymes convert the DHEA into both estrogen and testosterone, but only in the exact amounts that specific cell requires.
That is amazing. The cell acts as its own internal pharmacy.
Exactly. It synthesizes the hormones internally, repairs the cellular structure, and then degrades the hormones without them ever leaking out into the systemic blood circulation. It is true intracellular therapy.
And then you have a drug called osbemifene, which approaches the problem from the opposite direction. Osbemifene is an oral pill. You swallow it, so it circulates systemically.
Right.
But its molecular structure has been engineered to behave differently depending on the tissue it encounters. When it reaches the vaginal tissue, it acts just like estrogen, reversing the atrophy and restoring the low pH. But when it circulates to the breast tissue, it acts as an anti-estrogen.
It's incredible.
In fact, animal data suggests it may actively inhibit tumor growth in the breast.
It perfectly illustrates the future of hormonal medicine. We're moving away from simply flooding the system with a single hormone and hoping for the best. We are developing molecules that can selectively activate or block specific receptors in specific tissues simultaneously.
It's incredible.
Yeah.
We started this deep dive talking about the limitation of treating the whole body with a single systemic approach.
Yeah.
How the sprinkler system misses the roots. But between the microdosed watering cans, the self-sealing mucosal barriers, and systemic pills that know exactly which biological locks to open and which to bolt shut, Medical science is really rewriting the rules of hormone therapy.
It truly is.
Thanks for exploring this with us. We'll see you on the next deep dive.